Hi, I'm Dr. Sam Mann, and this is Beyond Conventional Medical Thinking. We have an interesting discussion today with Dr. Lynn Malha, associate of mine at Cornell and New York-Presbyterian Hospital. And Dr. Malha specializes in nephrology and particularly in hypertension in pregnancy. So she has a lot of experience and thoughts about it. It's a very common problem, and we're here to discuss it today. And welcome, Lynn.
Hi, Sam. It's good to be here with you today.
Right, wonderful to have you on the podcast. About what percentage of women who are pregnant do you think develop hypertension during pregnancy?
So it's really interesting because you have around 9% of people who get pregnant who have a known diagnosis of hypertension. So that's not due to the pregnancy itself. It's believed to be a pre-existing issue. And then on top of that, around 5 to 8% of all pregnancies will develop a rare hypertensive complication, or not that rare, hypertensive complication of pregnancy, which is called preeclampsia. There are also women who get gestational hypertension, which is another hypertensive complication of pregnancy. So, all in all, having a high blood pressure from different potential causes during pregnancy is not an uncommon problem.
Right. And there had been controversy for many years about how high a level of blood pressure should be accepted without treating it. What would be the criterion? Blood pressure above what level is it recommended should definitely be on medication?
Well, you're right. The guidelines have really differed across continents and across societies for the longest time. I think we are now, for the past few years, all hopefully coming together. And we're defining 140 over 90 or below as the target in people who have known hypertension. So it used to be believed that if you have high blood pressure and you're pregnant, you're better off being off medication and just monitored for your blood pressure throughout your pregnancy. Why? Because there was this concern that if you drop the pressure too much, you may have less blood flow to the placenta, and that could be harmful. And that fear has really kept treatment at bay and only reserved treatment for people who went above 160 over 110, which is a dangerous blood pressure in pregnancy, and the risk of stroke is higher. So they only treated people who are in imminent danger. And that really changed after a big landmark study called the CHAP Trial, um, had that compared treating as the conventional treatment was in the United States at the time to less than 160 over 110, so not giving medication unless the blood pressure is in a dangerous range, to keeping people to less than 140 over 90, which was aligned with the non-pregnant guidelines at the time. And that study was clear that there is benefit for mom and child to keep the blood pressure less than 140 over 90. So using medication, if you want, before the blood pressure is dire, has been in big part changed after the CHAP study, because now we know it helps, we know it's safe, and it improves outcomes. So right now the guidelines are all aligned to keeping the blood pressure less than 140 over 90 throughout pregnancy in people who have known hypertension. It is not clear that this is what should be done in people who don't have hypertension but develop something such as preeclampsia, because the CHAP trial was for people with what we call chronic hypertension or pre-existing hypertension. But I think more data will come to light, and it is now accepted that you should treat hypertension in pregnancy, which was not the case, let's say, even 5 or 10 years ago.
Right. It's interesting also when we measure blood pressure, the typical recommendation to get an accurate reading is to put on the cuff, have the patient sit for 5 minutes, and then take 3 readings. I think we would agree that in a lot of clinical situations, that's not done. The patient's just rushed into the room, get a pressure right away, and that overstates the pressure. Um, my experience is that women in pregnancy when they go to an obstetrician and the blood pressure is quickly measured and it's high, and then they're told, okay, maybe you better sit in the labor room for a while and let's recheck it. And then they sit in the labor room, uh-oh, what's happening? And then when it's checked, it can be that high or higher because, uh-oh. And do you find that a common problem with women who you see who are pregnant and are told they have high blood pressure?
Yeah, this is clearly something that's well recognized and well described, not just in the literature, but in clinical practice. It is very vulnerable to be pregnant and to be at your obstetrician's office because you're always waiting for the other shoe to drop. You're waiting to see if the baby is okay. There's also the scenario where they're trying to look for the heart rate of the baby and they can't find it. That's when the blood pressure really goes up. So that is well known. And I think it's really important to point out the fact that most offices, unless this is an office that is really specialized or really determined to determine what your true blood pressure is and to measure it as per guidelines and have people sit and check multiple readings, will do it in a more expeditive and more corporate way, which is you come in and someone checks your pressure and you may have a fakely elevated or maybe appropriately elevated if you're concerned blood pressure. But our obstetrician, as you said, have have a protocol for that because they know it's very common and they have people sit longer and they recheck it later. There's another protocol that's really important, and that's a whole program we have at Cornell, which is home monitoring. Home monitoring is more accurate than office readings, and at least some part of the obstetrical community have, I want to say, the means and like the personnel to do that. And I think this has revolutionized a little bit hypertension in pregnancy, where at least I'm going to describe the program we have here, where every single patient is trained on how to check blood pressure with their cuff. And then they go home and they check their blood pressure as instructed. And the device automatically puts it in the computer on a flow sheet. And then there's a nurse who monitors all the flow sheets. And if there's a high reading at home, they get alerted. So for a lot of those patients, when they have the high blood pressure in the clinic, they actually can review their home flow sheet. And for all of my patients, I do teach them extensively how to check their blood pressure correctly and follow the guidelines. As you said, you need to have your back support, you need to have your feet flat on the floor, you need to have your arm rested at your heart's level. And you need to do 3 readings in a row without peeking in between and seeing what the reading is and getting aggravated. And I always check their home blood pressure monitor and compare it to a manual reading that I have in the clinic to make sure it does match and that the numbers they're getting are accurate. So I agree with you. I think it's a great concern that in different settings, especially in a medical office, the blood pressure can be elevated, but we are really trying to minimize that effect because we're basing our home regimens to the home monitoring. Again, there's another part to this that is important, is that in cases like preeclampsia, which is a complication of pregnancy, the blood pressure could be normal, completely normal, and then a few hours later be very elevated. And I think it is appropriate for those patients, even if they're just freaking out, but their pressure is elevated, not just say, yeah, but it was normal this morning, I'm probably fine, I'm going to leave. If the blood pressure is truly out of character for that person, the correct or the more advised way would be to get them in, get some lab, check on the baby because blood pressure could be a red flag for something else going on with the baby. Check on the baby, get some lab, making sure they don't have preeclampsia because they could have normal blood pressures and normal labs. And again, a few hours later, that could change. And then they should be released if everything is fine. But I think home monitoring can help you remove that white coat effect or anxiety effect. But at the same time, hypertension pregnancy can move fast, and having a normal blood pressure at home does not mean that your blood pressure will stay normal the whole day.
Right. And women who have elevated blood pressure, so the recommendation now above 140/90, they should be on medication. The typical medications that have been studied and proved to be safe in pregnancy, what would be your short list of choices?
Yeah, that's another part of changes in guidelines and different country and different entity recommending different things. In the US, the American College of Obstetrician and Gynecologists, or ACOG, is the bigger entity in terms of recommendation, in terms of pregnancy related everything. And their guidelines have listed as first line methyldopa, which is a really old, well-trialed and known drug that has a decent amount of side effect, and it's not always easy to find in pharmacies. Labetalol, which is a beta blocker that is a 2 to 3 times a day drug and has been around for decades and is very safe. And nifedipine, which is a calcium channel blockers that should be taken once or twice a day. And those are the 3 first line. The AHA also has commented on pregnancy and seems to kind of agree with the ACOG guidelines. So there's no controversy really for those. Those are first line. But everyone is so different that sometimes someone could be, for instance, allergic to this one or have side effect to the other one. So there are other medications that are safe in pregnancy. But those are our first line management.
Right. And they're pretty effective and they've been shown to
They
be.
are effective, they are safe. So again, to refer you to that CHAP trial, it's not just that they are safe, right? We've known they're safe for decades now. But it is also that they help improve outcomes. So it's beyond safety. It is helpful to be on them.
Right.
And if someone is pregnant and has a blood pressure above 140/90, it really needs to be decreased. And those medications are helpful.
Right. And the 2 main complications that we're trying to prevent and are effective in reducing the likelihood of developing either preeclampsia or premature delivery.
Yes. So, I think we can think of 2, and there are 4 subtypes of hypertensive disorder in pregnancies. But for most people, the easier way to look at it is there are basically 2 main categories. There are the people who have hypertension before pregnancy. And sadly enough, a lot of those are not even diagnosed before pregnancy. They know about their hypertension on their first obstetrical visit or second obstetrical visit. Why? Because a lot of people of reproductive age don't have close follow-up or a lot of healthcare exposure before pregnancy. And that pregnancy is often the first opportunity to diagnose pre-existing condition or chronic diseases. So there are the people who have hypertension before pregnancy, whether they know it or not, and that's typically diagnosed before 20 weeks. And people in that category, you really want them to be controlled in terms of blood pressure for multiple reasons. First of all, if your blood pressure is really elevated, you're at higher risk of stroke during pregnancy. If your blood pressure is elevated, you're at a higher risk to need to be delivered earlier. And when a baby is born earlier, they're premature, and that can cause a lot of complications. And there's the other category, which is hypertension that is kind of induced or triggered by the fact that the person is pregnant. And that includes gestational hypertension and preeclampsia. And both of those are hypertension that is developed after 20 weeks. Preeclampsia is actually a disease of the placenta. You see the effects in the mom, but it is not a maternal disease. So the placenta is an organ that's made by the fetus for the fetus. It's the interface between mom and fetus. It gets all the nutrients from the mom through the bloodstream and returns all the waste products. So that organ can malfunction, and that will lead to a series of events, which are release of substances in the mom's bloodstream that is going to damage the mom's blood vessel lining. And that leads not just to high blood pressure that is out of character for that person, but also you can have protein in the urine, high liver enzymes, low platelets, changes in vision, terrible headaches, and sometimes even seizures, and that is called eclampsia. So you can have all of those happen in the mom, but the triggering event, the original problem is the placenta. So it is not, at its inception, it's not a maternal disease. Gestational hypertension is when you get high blood pressure after 20 weeks without all those organ damages. And they're thought to be mechanistically distinct entities, but there is overlap. And a lot of times someone who is diagnosed initially with gestational hypertension because the only thing we find wrong is the blood pressure, but then you start seeing organ damage and the final diagnosis ends up being preeclampsia. So those are 3 categories I named so far. The 4th category is people who have chronic hypertension and then develop superimposed preeclampsia on top of it. And blood pressure control has been found to decrease the risk of having just like gestational complications such as preeclampsia or need to be born preterm for the baby. But also the other thing that has been shown to decrease the risk of preeclampsia is to be on a low dose of aspirin. It is not just safe, it does decrease your risk of preeclampsia if you had a high risk for that disease. And the list of high risk criteria changes from one country to the other. Again, there's a lot of variety, but it is a very effective and safe preventative treatment.
Right. Are you saying, would you recommend that anybody who has hypertension in pregnancy should be on aspirin?
Yes. So anyone who has hypertension or diabetes or an autoimmune disease or is having a multi-fetal gestation, so twins or triplets, or has kidney disease, all of those people unequivocally need to be on aspirin during pregnancy. Now, there are minor risk criteria, and then if you have more than one of those minor risk criteria, you may need to be on aspirin, and that includes high BMI above 30, age, IVS. There's a lot of different other, if you want, combination of risk factors that would require you to be on aspirin during the pregnancy to decrease your risk of preeclampsia.
And so it's interesting. What you're saying is that most women who have hypertension during pregnancy will have a normal pregnancy, normal duration of pregnancy, will not have preeclampsia, and the risk of preeclampsia can be significantly reduced by controlling the blood pressure if it's running above 140/90. The importance of checking the blood pressure at home and how often, I guess how often depends on what the blood pressure is running, but generally how often, because people who check their pressure 3-4 times a day, it becomes a self-fulfilling inaccuracy because of over worrying.
Yeah.
How often should they check their blood pressure?
So I think it's also important, as you said, it all depends on what the blood pressure is running at. It's also important to take into account what we're expecting. So early in pregnancy, in the first 20 weeks, the blood pressure just naturally decreases. And that's true of people with hypertension, just like in people who don't have hypertension. The blood pressure is lower all the way until really 20 weeks is the lowest. And then 20 to 28 weeks, it kind of recovers from being so profoundly decreased or low. And it's really the hormone of pregnancy who are driving that decrease in blood pressure. So pregnancy is an antihypertensive early on. And that's why a lot of people who even are on medication may need less medication in that first part of pregnancy. And then when you start going to the end of the second trimester and in the third trimester, the blood pressure starts recovering. And after 34 weeks, it really is slightly above what it was even pre-pregnancy for those people. And then you're higher and higher all the way into term. So in the original part where we're only expecting the blood pressure to be low and lower, if your blood pressure is okay, it might be okay to just check it 3 times a week, just like in a ballpark, because we're not expecting the blood pressure to start going up. And by definition, it's exceedingly rare to diagnose preeclampsia or hypertensive disorder before 20 weeks. So in the first half of pregnancy, it is safe to say every other day is more than enough, or 3 times a week. Then when you get later into pregnancy, and that really depends on how the person is doing, but I would say after 24 weeks, usually I ask people to just start checking it once a day, every day, but then check it at different times, because we all have a circadian rhythm, and it looks like during pregnancy, blood pressure is kind of highest in the evening and lowest in the mornings. Everyone is different though, and that's why I check it once a day, but check it at different times. But what I care most about is that it's checked properly, just, as the patient has been trained.
Yeah,
Not when they're rushing.
it's interesting because among non-pregnant patients, studies also show there is a blood pressure surge. It could be mild or not mild. In general, people with hypertension, when they first get up in the morning, their pressure can be higher than it is the rest of the day. And so I think it's important. And I'm not discussing pregnancy, but in general, if you're following your blood pressure, just be aware that that first half hour or so, it might be a little bit elevated. and don't go solely on the basis of the pressure when you first wake up. Does that rule hold for people who are pregnant, or is it different?
Not that much, right? Because the circadian rhythm is very different. Because, I mean, the response that increases a response to cortisol, right? The response to cortisol is slightly altered in pregnancy. So you may have a slight morning surge, like we say, but it is not in pregnancy, it is not necessarily an exacerbated morning surge state. You have a surge like everyone else because your cortisol is going to wake you. But in pregnancy, you also have that increase. I wouldn't say placental fatigue because that's not a real term, but you do have a higher blood pressure in the evening. And the thought is that you've been walking around, you've really diverted a little bit of flow from your placenta, and you need a little bit more rest earlier in the day before the evening. So it's not really clear, but it's a pattern we've noticed again and again. It's been described that in the late afternoon to evening, for a lot of people during pregnancy, the blood pressure could be a little bit higher.
Right. Is there anything that you would suggest that a woman can do prior to pregnancy to reduce the chance of developing hypertension in pregnancy or preeclampsia?
Yeah, I think there are two main things. So there are certain risk factors for preeclampsia or hypertension in pregnancy that are modifiable to a certain extent, and that is trying to minimize the body mass index or weight for the height of that person. And the closer to a normal or appropriate weight for your height you can be, the better. The risk for all hypertensive disorder and other disorders too, such as diabetes, gestational diabetes, is higher in people who have higher BMIs. And all, like ideally, you would really want to try to get that BMI below 30, or lower is better. So that's one thing. The other thing is trying to increase, I want to say, physical fitness, because pregnancy is difficult on your body, on your muscle, on your skeleton. So if you have a little bit better exercise tolerance and better muscle structure going into pregnancy, that may make it a smoother process for you. Now, so those are kind of modifiable risk factors. Now, the non-modifiable risk factors, which is chronic diseases, right, such as autoimmune diseases like lupus, or if you have hypertension, or if you have diabetes, or you have kidney disease, you want to make sure you're optimizing those medical issues. So you want to make sure your diabetes is well controlled. You want to make sure that your lupus has been quiescent, or your autoimmune disease has been quiet. And you also want to make sure your blood pressure is well controlled. And all of that needs to be done with pregnancy safe drugs. So if you know you're planning a pregnancy, you really want to make sure that all the medications you're on are basically safe to be used in pregnancy. Because if you can control someone's blood pressure or sugars, but then you can't keep that management when they get pregnant, then you don't know that you're really controlling it because they're going to stop those meds. So you want to make sure that you're controlling your chronic issues with pregnancy safe medication, and that you're minimizing risk factors that can be changed.
So, any final thoughts that pop into your mind to conclude with that you would want to convey to women who are about to or are pregnant?
Well, I think there are two major things that I really feel very strongly about that are under advertised. One of them is more education and to be aware of all those hypertensive diseases. There's a lot of people who hear about preeclampsia for the first time when they actually are diagnosed with it. So I think to learn more about that, not to scare them, but that if it happens to them, because it's not a rare disease, 3 to 8% of all pregnancies are affected with it, no matter how healthy you are, your placenta can attack you. And I think it's important for people to be aware of that, and also to be aware of what is their blood pressure, how is their health going into pregnancy, because pregnancy is often the first opportunity for people to be diagnosed with things that we wish we diagnosed earlier so we could optimize it before. So that's the first thing, is to be more aware about your hypertension status and be knowledgeable about the fact that that can change and preeclampsia can happen. The other thing is all hypertensive diseases of pregnancy, but especially preeclampsia, are associated with a higher risk of having hypertension, any vascular disease, any metabolic disease, kidney disease later in life. it is a risk factor for a lot of diseases such as hypertension, metabolic disorders, strokes, heart attacks, kidney disease. And it is often unrecognized because after you've had preeclampsia, your body heals and you have a new baby and you're still relatively young and you kind of forget about it. And I think it's really important to emphasize the fact that all preeclampsia survivors are survivors and their blood pressure may look pristine and their kidney function may look perfect and everything may look great because they healed, but their blood vessels really never forget. Is it that preeclampsia is a manifestation of other risk factors that they had and later in life they were already in a higher risk to get all of those vascular diseases? Maybe. But there's also the concern that there's something that changes after a preeclamptic attack that you really don't get back, no matter how perfect your blood pressure looks after preeclampsia. So I think it's twofold. I want people to have a little bit more awareness about hypertension and the risks during pregnancy before the pregnancy, but I also want them to know that after the pregnancy, they really, if they've had hypertension in the pregnancy, really need to be more adherent to their yearly physical, keep track of their blood pressure, maybe check it like once a month, just to make sure that if and when they get hypertension or metabolic disease or kidney disease, they're diagnosed early and handled appropriately.
Oh, thank you. You know, it's amazing. We're talking about the problems in pregnancy, but the truth remains most pregnancies go well. Pregnancy is one of the incredible miracles of nature. It's beyond the imagination of how does this happen? The dumbest animals on earth can have the same miracle, and they're even dumber than people, some of them. Not all, but some of them. And what a miracle of nature it is. And yes, we talk about handling where it's a problem, but the bottom line is what a gift pregnancy is to mankind.
I totally agree. I think, we talk about the difficult things so that in people who get it, they don't feel alone and they know it was a risk and they feel supported. But it is true, the majority of people will do just well. Um, it's one of those things that you don't know what you're gonna get.
Yeah. So we'll stop there. And thank you for your attention. Again, if there are any comments or questions, the um, website is drsamuelmann.com. And thank you for your attention.
Thank you.